Scalpel, check. Hammer, check. Vibes, always sterile. Welcome to Scrub. Welcome, everybody, to episode 7 of the Scrubbed podcast. We are back stronger than ever with Dr. Linda Suleiman today. Alongside me today is Kinley Hatch, my athletic trainer and my assistant in the OR, as well as on Scrubbed podcast. So welcome, Kinley.
Thank you so much for having me.
Of course, always. And without further ado, today we're going to talk with someone who is awesome, a pioneer in the field of orthopedics, a pioneer in the field of being human and providing care in areas where really desperately need care. So today we welcome Dr. Linda Suleiman. In way of background, Dr. Linda Suleiman comes to us from initially Howard for undergraduate. She had completed her residency at Northwestern, followed by fellowship at Rush University. She is a phenomenal advocate for access to total joint arthroplasty, of which she is a total joint replacement surgeon. When it comes to things outside of medicine, or I guess inside medicine, technically, she is a staunch advocate for equity as it comes to improving representation in orthopedics from all groups. In fact, to the point where she is actually the Dean of Health Equity at Northwestern Feinbaum, where she currently resides. And as we will talk, she is involved in many, many things like the WOGO. I think I don't know if you call it WOGO, but I hope it is, which is a really cool global outreach program that it involves women to provide joint replacement surgery all over the world, not just in the United States here. So I could keep going, but I'll stop. I'm talking too much. Welcome, Dr. Suleiman. How are you?
Good. Thank you so much. Please call me Linda. It's really great to be here and talk to another surgeon and just talk about life. And you've had some phenomenal guest speakers on this podcast. So really honored to join the ranks.
Yeah, absolutely. Yeah. I mean, we've been blessed by the folks who are willing to come in and talk with us. There's no doubt about it. I think Kinley and I, every single episode we do, we kind of think like, oh my God, I don't think it can get any better. But then Kinley, what do we always say after each episode?
For every single episode, as soon as I hit hang up, I text him and I say, wow, that was amazing. This is going great.
Yeah, it only ever gets better. So no expectations though, Linda.
Yeah, no
So
pressure.
let's get into it a little bit. You have a very interesting upbringing. And I think probably my guess is that it informed a lot about what you do with orthopedics and how your career has been molded. So would you mind chatting us a little bit about growing up and what brought you along the path that you got to?
Sure. So I was actually born in DC when my parents were working there, specifically my dad, and we actually had no plans to ever stay. I'm originally from Somalia. Both my parents are from Somalia. They grew up in Mogadishu. And as the mid 90s, still till now, it's a really tough situation in Mogadishu specifically. But we went back to Somalia. My parents, were in their late 30s. And I'm just sort of thinking about it. I'm 39 now, about to be 40 next month. Like, I can't imagine picking my life up and leaving in the middle of the night with no plans, just need to get to safety with children and starting all over again. I really, kudos to my parents. They're the most strongest people that I've probably ever met and very resilient and have always taught me and my siblings that if you have a good education, you can make it anywhere. And so I think education and people and kindness is what drove them. I remember immigrating to Canada where I grew up in Hamilton. It's, a steel town, a huge immigration population for Canada at the time, just outside of Toronto. And it's actually the largest Somali population in North America, second being Minneapolis. So you would think, Africans, why are we going to the coldest places on earth? I don't know. We will go where there's other Somalis, essentially is the gist there. It's been a journey and it's been amazing. I'm really blessed to have made it this far. I would never have imagined becoming an orthopedic surgeon, let alone any other, exert whatever titles you want to put in.
So the 90s, correct me if I'm wrong, but I believe that's kind of when the Somali Civil War started. Do you remember anything like, do you remember the climate when you were there? Like, or was there feelings of unease or kind of like danger? Or like, what was the like feeling if you have any memories?
Yeah, it's funny, as a kid, it felt like I imagine my child now who's 6 years old, like it just felt like a normal life, right? Of what you're used to. We lived amongst family. Everybody lived next to each other in like compounds. And then it felt very, for me, like I didn't feel the angst, right? Our parents like really insulated us. I think the community really insulated the kids around this. And that's why I think it felt so shocking, just like we're up and leaving and we're gone pretty quickly and quietly, right? You really couldn't tell people you were leaving at the time because of the civil unrest. And it was very tribal, right? And so if your tribe wasn't the happening tribe and that was leading the country, you had to kind of get out of there. So I don't have memories of like doom and gloom of what was feeling. It just felt more like a surprise, like, well, where are we going and why are we going? But it was this comfort and safety, like your whole family was leaving. So I guess, we're all going.
Yeah. Yeah, that's something that, for me as a father as well, like I kind of have to put take my children's perspective whenever we go through something. And you're right, as a kid, it's just, oh, mom and dad know what's up. Mom and dad know what's going on. They're going to protect us. But until you become a parent in so many ways or you become older, you don't really realize what your parents are shielding you from. I mean, I can imagine how nerve-wracking that was for them.
Well, also, my parents, they left much earlier, probably a year before the year or two before, I would say, the real turmoil of what you saw on TV of what the Civil War looked like, because they felt it, they knew something was coming. And they were the only ones to leave. Like a very small group of family members actually left. I remember my aunt telling me a decade or two later, like, your parents were the smartest people for going. Because we all thought, like, you're insane. Nothing's gonna happen here, right? Like, there's no war
Yeah.
coming. Like, this is just the usual. But, I really give it to my mom specifically that she was like, something does not feel right here. It's going in the wrong direction. And she was an anesthesiologist. So like people really thought she was crazy. Like, you have a great job. You're a doctor. You're one of two female anesthesiologists in the country. You trained outside of Somalia. You're educated. You're smart. You've got a great life. Like, you're gonna go and work at like a racehorse track in Fort Erie, Ontario? Like, that's where you're going? And my dad working as a janitor in the same racehorse track? Like, it listening to it, I was like, "You guys are insane." Like, I would not
Yeah.
do that, right? So I really give it to them for I think taking the path that wasn't popular, and it's probably what's driven me is sometimes that path isn't popular or cool or exciting or sexy, but it's maybe the right path for me.
How
Well, and I'm
how
a
did
firm
your
believer. Sorry. I'm a
No, go
firm
for it,
believer
Kayla.
and you gotta figure everything's gonna be hard. Life is gonna be hard. It's gonna be hard if you stay, it's gonna be hard if you move. You have to choose your hard. And it sounds like that's exactly what your mom did, is she weighed her options, she trusted her gut and was like, I'm out of here. I'm gonna choose the hard.
It's like, I'm choosing the racetrack.
Yeah.
Jack.
How did she end up in anesthesiologist, how did she end up in Somalia?
So so my dad, he worked in business and ended up working with the port authority. So he's sort of like an import export guy. Mogadishu is right on the coast, so there's a lot of the path of what would come in and out. And he was sort of the government representative at the time for that. My mom, her mother never went to school. My grandparents never went to school. My grandmother couldn't read or write, and my mom just sort of said, I want to be educated and I want to help people. So she ended up going to med school in Somalia, but she went to Rome. So Mogadishu at the time was actually colonized by the Italians. So my parents speak Italian. Everything was in Italian. There's no written language of Somali until the mid 70s. Everything was storytelling. We're a culture of storytelling. And so she ended up going to Rome to do some residency training. She ended up doing a fellowship in Saskatoon, Canada, like Saskatchewan for a year, and then came back and thought, like, I'm going to get this global training and come back and help my people. And there's no women at the time doing anything but, primary care or OBGYN in Somalia at the time. You delivered babies or you just took care of the community. And she was like, I kind of want to be in the OR. So she loved it. And she's a bold lady.
Yeah, they both sound pretty legit. So was that what ended up bringing you to Canada? Was she had experience in Canada, or was it the Somali population? Like, what was the driver there?
Yeah, so Canada, like it is a very welcoming country, I should say, to immigrants and newcomers. And at the time, they were taking refugees from Somalia as like the climate just was getting a little bit dicey there. The UK was taking a lot of people to London, so we knew some people going to London. The US at that point really had not opened its borders until post Black Hawk Down to Somali immigration. And We actually got sponsored by like a church group in Fort Erie. And so it was sort of random. We had no idea where Fort Erie was. It's a really small town in southern Ontario, right across the border from Buffalo. And we were there for about 2, 3 years, getting our feet wet, getting papers together, and then we ended up moving to Hamilton, where there was this settlement integration sort of nonprofit that started, and they wanted newcomers to help with that, right? So it doesn't help if it's Canadians helping newcomers, like you don't know the experience of what's coming, but you'll bring in the immigrants who are coming to help other immigrants. So that's how she got involved with nonprofit work. But there was like a sadness about it for her because she couldn't practice medicine. She didn't have the licensure and really didn't have the opportunity to restart over again because she had three of us plus some cousins of mine who came with us. And so you sort of had to make money and pay rent and put food on the table. And I could sort of see that growing up. Like she just really missed that part. Like she still was helping people, but not in the manner that she thought she was going to do.
Does she does she still kind of one is she still with us?
Yes, yes. She was, my parents live in Hamilton. She works for Pathways Canada, which is still, helping newcomers with education. And
Yeah.
so it's a government funded program she's been working with for a while. She's always been in nonprofit community engagement work with new immigrant populations.
Yeah. Well, something you mentioned earlier, which I think is extremely applicable here, is that you never know what lane you're going to help people in, right? And I think the only thing that defines like our soul, like our inner driver, is like, what do we care about doing? And I think for healers, which we all are on this podcast right now, and a lot of the people listening to it are healers, I think there's kind of an insatiable need to help people. And whether that be by putting them to sleep and waking them up and all kinds of crazy stuff that anesthesiologists do. I don't really, as you know, I don't really know that much about it. But versus a nonprofit, right? There's so many different ways that we can give back to this world. And medicine is just one small.
Absolutely. I think the beauty of it is it's what you feel, right? It's like what drives you and what wakes you up every morning. And I think community work and medicine, it's about people and it's about relationships. And I think those are the two things I've always valued. So she took those same skills and did it in a different way, probably more in an important way because you can't really get to a doctor who have no place to live or infrastructure or papers or like just getting the suit for the interview and getting food on the table. And so it's funny, I talk to her about this all the time. Like she really is what inspired me to start thinking about social determinants of health and how that really applies to orthopedics and how it was never talked about. Because we think about, knife, cut, move, put the implant in, and that's all you need in life. Um, but it's really about the whole person and understanding that person as a patient.
Yeah.
It's funny you say
Kinley, I
that. Every time I see a patient, I always, "Oh, how are you?" And they say, "Oh, well, my knee hurts, my back hurts." And I always stop them and say, "How are you as a person? I care about you that too." I think people forget that when they go to the doctor. And people are just shocked that I even asked that. And so I totally understand the whole person, the compassion, the heart behind it, because people are still people at the end of the day.
Yeah, I hear that every time she comes down the hallway, and it's still special every time, you know? I mean, it's amazing, right? Like, as a doctor or as an athletic trainer or whatever, as a surgeon, the amount of value people find in you just asking them, "How are you doing?" You know? How's your day? How is life right now?" They almost act like it's like something that a healthcare provider or a surgeon or an athletic trainer is not required to do. And I find that very disappointing, right? Like it's like we went into medicine to help you.
Well, I think even more so, like, I think surgery historically has felt so transactional, right? Like, I have X problem, I'm going to fix it, and you move on, right? And it's so compartmentalized. And I think that's why we really haven't moved the needle forward in disparities, why we haven't really moved the needle in how we're accessing and helping people get access to joint replacement, specifically in my area. It's because it's been transactional. It's been too transactional.
Yeah, there's no question about that. I mean, if you look at essential services, right, like emergency medicine, you know, time and time again, we've proven that there's major socioeconomic disparities in access to this basic level of healthcare. But I think the thing that people don't understand about orthopedics and that they should is that those same disparities exist. And, one question I was going to save to later, but now it's a great time to talk about it is, do you think that we are biased against elective surgeries, like total joint replacement surgery? Do you feel like we're not talking enough about the type of patients that we're operating on, the type of cherry picking that occurs? Because at the end of the day, society wants surgeons to have good, easy outcomes, not spend a lot of money. And I think joint replacements, we get nervous about operating on patients we think might not have quote unquote have a good outcome. What do you think about that?
I mean, I think it's one, and you've had Kevin Bozick speak on bundled payments and value based care. What we forget about, and if you talk to any of our primary care colleagues, so I'm married to a cardiologist, and he tells me all the time, like, they talk to me about their knee or hip or whatever is aching them more than the heart, because the heart is silent, right? You don't feel it, right? But you feel your bones, your muscles, the aches and pains that affect, can I work? Can I walk? Can I do the things I need to do to stay healthy? And I think that's where we've missed the mark in US healthcare is musculoskeletal focus entirely. Because imagine if you could help patients, right, from a musculoskeletal standpoint, they're going to be healthier. You're not going to be spending money on diabetes medications. You're not going to be spending money on hypertensive medications, obesity. I mean, the list goes on that's related to the fact that like a person can't move. And so instead of putting in effort into musculoskeletal prevention and good outcomes and the whole episode of care of how, just for example, a joint replacement works, we wouldn't have these primary care issues that we're having. I truly believe that if we had focused on and not been so siloed in like the diabetes, the heart health, all these things that we think help happen separately instead of like the person, the body, the musculoskeletal, like who's carrying this heart, right? And lungs and these
Yeah.
issues. That's where we've missed the mark. And that's where we're now at the point of, okay, our spend is now too high in joint replacement. And so I'm going to follow, okay, Dr. Suleiman, I need to know that people aren't getting readmitted. People aren't going to the ER. People aren't spending money on home health care and PT. Like we need the least spend possible. So I'm probably going to pick a Steve or Kinley who look pretty healthy to me, who are going to follow my directions, who have some sort of health literacy, than the person who actually needs the joint replacement, who can't walk, can't do a job. They're on disability. They can't do the things they need to be doing. And now they have other issues of obesity and the diabetes. And, I don't have access to a primary care doctor. So I'm going to get my care at the ER. And so I think we
Yeah.
just completely missed the mark. And, with CJRX coming next year, we're all going to be back in some bundled form. The details of that are still pending, but I just really worry with reimbursements going down, the patients who actually need it are basically going to not get a joint replacement at this point.
Yeah. It's scary. I mean, I think at this point, kind of all paths leads towards worsening, to be honest, of socioeconomic disparity. Because at the end of the day, I think doctors are increasingly being punished for one extra minute of OR time, one extra, ED admission for elevated blood sugar after in the, 90-day window of total joint replacement. And I agree with your point wholeheartedly. It feels a lot like we're nitpicking, right? How do I save $20 on this joint replacement when has anybody ever asked this person if they can get like their diabetes injections, like the insulin, like we act like all of these things are completely siloed when in fact they're not because they're connected by people. And I think to me, that's the hallmark of a phenomenal doctor or surgeon or whoever is just to say, what connects you? What like it's the brain, it's the person.
Also, what makes it easier for surgeons? Like, it's funny. I get this question all the time of, you love technology, but technology is expensive. Like, how is technology going to help in this like cost issue, right? That we're all dealing with as joint surgeons. And what I think about is, if you look at Chicagoland, you know, all the fellowship trained surgeons are in like this one square area, right? Literally, where most of the patients who've got the higher KL grades, higher arthritic scores, pain scores, are 8-10 miles away in really low socioeconomic neighborhoods with low resourced hospitals. So there's maybe one or two orthopedic surgeons in those communities, and they maybe most of them are not actually not fellowship trained. Most of the fellowship trained joint surgeons are in a very high dense area of affluency, obviously, with these hospitals. Like they're going after those insurances, the commercial insurance payers. But what I like about technology is actually level out the playing field. So the number of patients that will travel and took them 2 buses or called 3 cousins to get them to me, downtown, they don't like, do I have to have my surgery down here? Like, I got a hospital across the street. It's a small community hospital, but it's across the street. My family can help me. I can get to the PT. I can get to my appointments much easier. And that's where I say, like, why don't we actually empower surgeons to do the same surgery I'm doing? You don't have to be fellowship trained, but can technology even out that playing field? So we're not asking patients to come to me. Instead, it's in their backyard. And so,
Yeah.
now we're not reimbursing technology and we're saying, okay, that's a cost issue. And again, we're just missing the mark on like the bigger picture of how we can actually improve access and lowering the resources that we're putting in if people can just stay in their communities.
Well, it's
Yeah.
also a higher rate of compliance and patient outcome if they know that my surgeon is comfortable doing the work here. I can do the best I can do. And it's a teamwork. That's all medicine is. It's working with the patient, it's working with the surgeon, and working with physical therapists and all of that to have this whole approach, multidisciplinary outcome for patients to have the best result.
So how did you get bit by the medicine bug? I assume your mom has a big role in it, but how did you get bit by the medicine bug, and then how did you get bit by the orthopedic bug?
Yeah, so I think for me, with my mom's influence, I would say it was a huge influence of why I chose medicine. I always have been someone, and it's probably the eldest daughter thing too, where you're always taking care of other people. My younger sister's a lawyer and the baby of the family, so I'm going to make fun of her in a little bit. But like we're complete opposites in that sense. But she, I always saw my mom doing everything for everybody else, and I probably was very similar to that. And I love science, but I never thought about orthopedics even in the little. So I didn't know much about it. Even being an athlete, I was a soccer player. You got your injuries here and there, but I didn't think about orthopedics was for me. So I actually chose Howard for med school because I wanted to do primary care and be in the community. And it was a very primary care, community driven medical school. Had a wonderful orthopedic surgery program, but it just wasn't what I thought of. And it was actually Bonnie Simpson Mason, who is one of the very few and first Black woman I had orthopedic surgery, who just came to Howard one day. She said that she was starting this summer internship between first and second year medical school for those women and minorities interested in orthopedics. And I walked by the information session and she's just standing, she's like, "Where are you going?" And I'll never forget her being, "Where are you going?" I was like, she's like, "Why don't you come learn about orthopedics?" I was like, "What the hell is orthopedics?" And I remember walking in, it's just like a room full of men. I was like, well, my odds here as a single woman in DC is really high walking into this room. Same time, I'm like, where are the women? And so she was like, and this is why you need to be here. And so, I did the program that summer. I was like, this could be cool. Like, you're still helping people. And I spent 8 weeks with George Russell at the University of Mississippi. Never been to the South in my entire life, never been to Mississippi, Jackson nonetheless. And it was probably the best 8 weeks I've ever spent in my lifetime. Really, it's such a tertiary care center. It helped, people who were hours away with orthopedic injuries, really, really poor communities. And they were doing a lot of community outreach at the time. So I was like, oh, so I can blend these two things. I don't just have to be the surgeon, but I can actually care about people and have the community based care aspect. And that's what changed it for me. It's funny, I just talked to George Russell, who's now the president of Gladden Society last week, and was like, I can't believe like literally 20 years later, I'm still talking to you every other month. And the
Yeah.
guy who made me go into orthopedics and obviously Bonnie Mason. But I think what ultimately ortho was about helping people in a tangible way that was, I think, pretty efficient. And I think I just saw the bigger picture then, but I probably couldn't describe it. Like, if I can get people walking and moving, I could probably get them healthy. And I think that's
Yeah.
ultimately was a bigger impact than me being at the time what I thought a primary care doctor could do.
Yeah. Do you remember, is there a specific moment in the OR that you were like, whoa, orthopedics is pretty sweet? Or is there like a certain surgery that you really gravitated to?
So the first ever orthopedic surgery I ever saw was a knee replacement, which is funny because I now do knee and hip replacements. And that was like the staple to me. I was like, this is orthopedic surgery. And everything else that kind of came with ortho, I was like, that's not ortho. It's a joint replacement, And so I just kind of coming back to that. But I don't know if it was the surgery itself. I think I just saw like what the person looked like before and what they looked like 5 weeks later. And I was like, damn, this surgery like really can do something. And like hips especially, right? And so I think for me, it was more the impact and it was still an evolving specialty. Like, I don't ever want to be in something that's stale. Like, I want to, curiosity has always driven me. And I want to keep thinking about how we can do these surgeries better, but like just the ecosystem of surgery better. And I think there's still a
Yeah.
lot of room for growth.
Yeah. Truly. Kinley, do you remember watching your first knee replacement or partial knee replacement?
Yeah, it was one of those that I was like, "Oh," because we've done so many scopes at that time that I was like, "Oh, this is a real surgery. This is knee filleted open. Got it. Perfect."
Yeah, I think the funny thing about that is that, a lot of folks have never obviously seen a knee replacement surgery, so I don't think that they realize we're using, a lot of the power tools that, you use like to construct your shed or something like that. So I think it's funny when you said that, Linda. It's like that experience, I think for most is like, "Oh my God, I can't do this." But I think for the real orthopod, it's like, "Oh my God, I only want to do this."
I was like, "This is a great surgery. This is awesome."
What's
Yeah.
funny is like in my household, I can use all the same tools, but I tell my husband like, no, I can't hang that. I don't know how to do that. He's like, you do this for a living. I was like, no, can't do it
That
at
makes
Yeah,
home.
you
me
can't.
feel better about also not wanting to do the drilling and the everything because 'cause I'm like, that's a blue responsibility. I do pink responsibilities around the house."
Yeah, you can't mix business with work. I mean, car
Yeah.
home and work, come on, you gotta keep them separate. Okay, so Linda, at what point, I would say at what point in your training did you start to look not beyond orthopedics, but in addition to orthopedics, where you started to take on leadership roles in terms of women in orthopedics with AUKUS. Like you've had all of these roles that are trying to improve the status of health equity in orthopedics. And you're right, it's a predominantly white male dominated specialty, and it desperately needs improvement in terms of equity. So, with residents being head down, work harder, do a million surgeries, at one point you got to stick your head up and say, but there's this other part of me that I so deeply need to feed. Like, when did you start coming into your own with that?
Probably say, in residency, we spent a lot of time at Cook County Hospital, and it was a vastly different patient population system of Northwestern. And I loved every day that I was at Cook County. And I think a lot of that is like, oh my God, I literally saw 90% of the patients were Black, right? Chicago's such a diverse city, but it's also so segregated. And so this was like the hospital of the catchment point of people who look like me. And it was so clear to me that getting access to elective joint replacements, we did so much trauma there, but our elective joint replacement list was so long just because we couldn't get to it because the traumas were so heavy. And it was really that point as a senior resident, I was like, I got to do something more than just operate and impact, right? Like, how can I tangibly change all aspects of this? And I think what I found so interesting was, at the time, all my attendings were men. I didn't have any female attendings other than at the children's hospital. And so I never saw a woman do a joint replacement or trauma or any of these other things. But I would watch these patients walk in and just be talking to me and looking at me. Like women would look at me, Black people would look at me. And like they're not even paying attention to what my attending was saying. If my attending said, okay, this is the next step, then they would look at me and be like, does this make sense to you? So there's this like trust. And I was like, oh, this is a really interesting relationship that I didn't really think about. And then you sort of think about like, why is representation in our specialty so important? And number one, it's the patients, right? It's something that we can't control. Like everybody has their own preference and trust in people and how we respond to people. And a lot of that is just who you're used to. And it's not a bad thing to have these biases. I don't think bias is necessarily a bad thing. It's being aware of these biases that make you not so great. But it's really about number one, the patient. Number two, if we're going to make what we do better, we need people who are coming from different experiences, who are thinking differently to make it better. And so I hate the fact that it's like we don't just need more women or need more minorities. It's how we're going to do orthopedics better, ultimately. I mean, that's just flat out. We've known this. The business world has known this. We're slow to know this. And then I started to think about like, what are the barriers of why we're not joining this specialty? And
Yeah.
I'm not going to lie. Like there was points in time that I was like, I don't know if I can be the only one. Like it's exhausting. It's exhausting coming to work and not feeling like you can be your entire whole self. And I think number one is culture change. And I think we've actually done a really good job of that in orthopedics over the last 10 years of this culture change and acceptance and seeing people as they are. And I think that's what sort of interested me into getting involved as far as leadership with RJOS and now being ACA's program chair. Like, it is so wonderful to be a part of the planning committee and running our largest global hip and knee society meeting and really putting the flares of like, how can we think differently? How can we
Yeah.
put new topics on that we're not debating here about another kinematic alignment talk? Like, we've been there, done that. What is affecting the surgeon today? And it's what I'm really proud of is our program committee is made up of 5 surgeons who all look different and who all bring different perspectives and different ideas under the leadership of Antonia Chen, who's our second female president of ACUS this year. And so
Yeah.
I think if we can think differently as a community, as orthopedic surgeons, by bringing in people who think differently, ultimately we're going to deliver better care for our patients.
Yeah, I think the conversation in here is echoing something that we talked about previously, which is we're kind of in an echo chamber, right, in academic medicine. I can't tell you how many times I've watched prosthetic joint infection debated. I mean, and people, it almost feels like the self-fulfilling prophecy where you have docs who are so adamant about it only can be this way. And it's almost like a lot of the lectures we watch are almost like kind of like emotional arguments over the same 30 things that we've talked about, but there's this other cloud of like 90% of things that actually impact the type of care that we're providing. And I don't think I've ever seen a lecture about, I mean, maybe unless someone has a paper about socioeconomic disparity, I've not seen a talk in real time of, hey, Linda, what are you doing with telehealth to address these disparities? Do you feel like we need to get out to the community? Do we feel like the community needs to get to us? I mean, do you feel like it's a disservice in orthopedics that we continue to talk about these kind of pre-canned topics, but not address some of the bigger things at play here? Or like, because I mean, you have a role now in a very large organization. Like, what's your goal? What's your hopes to kind of evolve this?
Yeah, so when Antonia Chen was program chair 3 years ago, we actually did a symposium on basically the ecosystem of the patient from the private practice perspective, how social determinants of health, how do you deliver it, and then the value-based care aspect of it. And so, what we've evolved to now is how can we bring in this importance at this AUKUS? Number one, we have to address the elephant in the room, which is our payments are getting cut, and we have colleagues who can't sustain their practices. We have colleagues who can't help the patients that I want to help because of these financial burdens. So, how can we be smarter, more efficient, and cost effective to better care? And third is how can we actually leverage technology to help us as surgeons from the time a patient walks in to helping them through the entire patient journey? What we've done at Northwestern that we've talked a lot about is really building the ecosystem of care. So, like, every single patient gets a SVI score. I know exactly where they're at risk from food, housing, before they even walk into my room. It's mandated because if I don't know where you're coming from or what you have access to, I cannot do a surgery on you, right? And so what I love about it is we're now leveraging technology to deliver. So if a patient is at risk because they can't afford medicine, we now have partnerships with GoodRx and other companies that deliver the medication to their literal room and like they got out of the operating room, they're in pack, you hear your medications, right? We're not searching for a ride to go to the pharmacy, how I'm going to pay for it. And then second, if you don't have food, okay, what zip code are you in? We've now partnered with Community Health as far as we know partners in every zip code in Chicago that can help us get you food and get you healthy food. And how do we figure out to get you the right job to then pay for your own food, right? And so as an orthopedic surgeon, I feel like now I'm not just delivering another knee or hip replacement, but I know you're going to eat well. I know your A1C is not going to jump back to 9 because you're back at the local corner store getting whatever is $1 that day, and that you're able to get the transportation you need. And I know you're not going to miss your antibiotics or your pain meds or anything else because it's in your hand before you leave. And so now we're like, okay, now the age of AI is coming along. Like, how can we leverage AI to make it even easier on us? Because the one thing I don't want is all these mandates and social determinants of health to feel like another job for us. Like, it really should be part of the care we deliver, but without our burden, right? And then third theme for us this year at ACUS under under Antonia is the surgeon wellness and burnout, because it is a very real thing. The number of surgeons who are leaving orthopedics is it's just becoming too much. And because of the culture we're in, we don't talk about our mental health or what's aching us or what's stressing us out, but it's a real problem, right? So that we're going to have a symposium on just the surgeon. Like, when was the last time I went to a meeting to talk about you, Steve, and what you're dealing with, and how can we help mitigate it and make it better for you as a surgeon and your family? So that's kind of
Yeah.
what we're centering on at AUKUS this year. We're really excited about it. And of course, our keynote speakers, Robin Arzon from Peloton, who's the ultimate wellness queen. So, I mean, it's going to
Yeah.
be amazing meeting. And we're hoping to just change the conversation.
Yeah. Props to you, Linda. I mean, that's probably the most innovative structure for a meeting I think I've ever heard. Like, and nowhere in there is like the let's talk about kinematic alignment with robot and without robot. It's like, no, let's talk about the stuff that everyone's just ignoring because it's uncomfortable to talk about. But it doesn't have to be uncomfortable, actually. It can be really awesome to talk about. I want to know what it's like for, you said this earlier when you were at Cook County. You're an orthopedic surgeon, you are an all star. What is it like to be representing, the Black community, the female community? I mean, what's it like when someone looks over at you as opposed to their attending? Because they go, no, I trust you, when you were in training. They go, no, I trust you, Dr. Suleiman. What's it feel like? That's got to be a heavy crown to wear.
Yeah, I think at first, like, I would look at my attending like, "Oh my god, I don't wanna offend you, you're right, like, this is your patient." But at the same time, I feel deep gratitude, honestly. Like, it doesn't feel heavy to me. It just feels like I'm really grateful that someone can see me and feel like they're in a comfortable space without me speaking. And I'm hopefully, after I actually speak to you, you feel even more comfortable. And there's patient encounters that's a complete opposite for me, who walk in and are like, "I'm sorry, you're the surgeon. You're the one operating on me." And it's like I have to build that rapport and relationship, and honestly, that's probably more exhausting for me than the opposite. But again, I also embrace that not every person is going to walk in and feel connected to me. I have to deliver something to them to make them feel like I'm going to take care of them through this entire episode of care. And I think the one thing, right, that we can lead with is kindness. And I think sometimes we forget about that because we're rushed to move to the next person. And if a patient says, "Oh, I'm not sure about surgery," it's like our brain switches off and it's like, "Okay, I've moved on. Here's your non-operative care. Good day." Why don't we actually ask people like, "Well, what makes you nervous about this? And why don't we talk about this in another month or two? Why don't you come back and see me? Here's something you can read. I think that could help you sort of wrap your mind around that, like, this hip replacement's really going to make you more mobile, even though I know you're scared about it." And I think we need to start pivoting into that conversation more so than just like, this is another RVU or a collection amount from whatever insurance company we're getting here, because at the end of the day, those are the patients who trust you, who are going to follow you through and actually end up doing better.
Yeah. And how many times is it, Kinley, how many times when we ask those questions would you say it's like it was something that like wasn't even relevant? You're talking about a rotator cuff repair and patients like, oh, I was told that I was not going to move my arm for 9 months. And you're like, whoa,
Yeah.
where did you hear that? I
Or
mean,
they'll be like, "Oh, I
yes.
looked online." Yeah.
Yeah, I mean, we're in a world of AI and people literally going online to see what their surgery is gonna be like, and by the time they get to you, Linda, I don't know about you, but I feel like half of my encounters are just dispelling, "No, that's, like, something that someone else does, like, that's not how it would happen here," you know?
And if I could get $1 for every time someone says, "You're cutting out my entire knee," like, no, I'm taking 9 millimeters of bone off each end. One tooth. But people, I mean, but that's the other thing is people trust their community. They trust who they hear, their family members. So I do try to respect that. Like, that's where their trust starts, and we're being invited in to have that conversation.
Yeah. So a couple questions about health equity. So, Linda, what's one thing that you've because there's a lot of trends, right? There's a lot of trends right now. Like, departments are increasingly, putting up like a DEI kind of department and things like this. What's something that you think that we're doing in orthopedics that might just be kind of missing the boat? Like, what do you think is the real recipe here for actually building health equity? Right? Not just talking about health equity or like hosting a whatever, a department day about it, but like actually building it?
Nothing will ever be built, in my opinion, in orthopedics without two things. Does it financially make sense? And number two is it how hard is it going to be for me as a surgeon? Honestly, I think if I had to make it as plain and simple logic, if it doesn't accomplish both of those things, then no one is going to do it. No one is going to take extra time or think about this patient or try to collect this information of where a patient is even coming from or helping them with access or taking the extra 10 minutes to talk to them about it unless it one financially makes sense and two you can execute it efficiently without not making more paperwork for me and more phone calls for my office. And so that's where I think you can make tangible changes. And how you make those changes instead of bundling things that we're doing right now of, okay, readmissions of this is going to get you cut, doing things, this implant cost is going to get you cut. Like we have to start thinking from the outcome standpoint. Like if I'm helping more vulnerable patients, right, coming from a community that maybe doesn't have the highest level of jobs, for example. But if I'm getting them walking and we're seeing the population health standpoint of how we're changing entire communities without the readmissions, without the infections, because we've got better access to technology, because they're able to access me, we're able to keep track of these patients in a more efficient manner. That is how equity is going to become. And it's not, we have to start thinking about these things in 90 days. Like I hate 90 days, 30 days, whatever days the government wants to put on us. Like let's really think strategically, like what impact this could have in a community in a year. Like, can we actually follow these patients and see what they're doing? Are they going back to work because they're moving better? They're not getting infections. Did their diabetes go down? So we're now spending it on more medication, right? Like, it's just we need to start looking at these things from a population health and public health standpoint instead of like the episode of surgery. That's the only way
Yeah.
health equity is actually going to be accomplished. And we can't do that alone as surgeons. Like we have to bring everybody into this conversation from the primary care docs, from the PTs, from the social workers, from the community members. Like it really truly needs to be this multidisciplinary approach. And my research team, it comes from all different lenses for that reason, because you can't do research in communities without community members, right? You can't do and know what people need without talking to the people. I don't know, what this insurance can or cannot provide without my social worker. My social worker sits in my clinic. Like when I tell people like, orthopedic surgeon, why the hell do you have a social worker in your office? I'm like, that is the most important person here. It is not me.
No
It
question.
is not like, as soon as we say, okay, a person is a candidate for surgery, Melanie, our social worker, is probably the most important person because we gather the information. We figure out, okay, what is it that you need to get through this surgery efficiently? And she's like, okay, they have this secondary insurance. We can do this, 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 and this. I'm like, I didn't even know that. Right. And so I've learned so much by just surrounding, again, people who think differently, who are from different aspects, who can bring, real life experiences and access to information that we as surgeons are not taught.
Totally, totally. Diversity of opinion is really diversity of perspective and opinion is really where all of this matters. I mean, we talk so much about whatever race, ethnicity, this, that, or the other, but those things are important because those people carry a different perspective. If you have 10 people in a room that all have the same upbringing, they all have the exact same perspective, you're probably not going to go very far. But if you have 10 people who all came from a completely unique perspective, then you can only imagine some of the things that you can accomplish. I mean, you've accomplished something amazing, which I want to talk about because it relates to the building that you're doing in your community, which is you've gone abroad and actually done joint replacement internationally. So one, I want to hear about your first experience doing that, but two, I want to hear about how you've learned to care for those patients, and to I don't want to use the term parachute surgery. I think it's a little bit derogatory, but like, what have you done to try and make sure that those folks like that they're going to do well, that they have access to like kind of follow up stuff like that. I mean, it's kind of the exact same thing you're talking about doing in your community, but doing it at a higher, like at really a more intense level kind of thing.
Yeah, so Operation Walk, I'm sure many people have heard of, are in different cities and it's been around for a long time. It was founded by Larry Dorr and we were founded, we were an Operation Walk team, but we were Women's Orthopedic Global Outreach or WOGO, which is a Operation Walk team, except we don't live in the same place. Number one, we are 10 women joint surgeons who live across the country. And our mission is to empower, educate, and engage. And it really centers around not just coming, putting in a knee replacement and see you later. Like we come from it from the perspective of how can we empower the in-country surgeon from the distribution of the implant, from the protocols, from the education around doing a joint replacement. And a second is the community. So we partner with Souls for Soul, which is a shoe brand company where it is imagine like the shoes that our patients walk in with to do a joint replacement are sandals, right? Not even from a safety perspective, but how can we just bring the shoes for them to rehab in? Like things that we don't even think about and we take for granted is like just putting on shoes after surgery that are appropriate for you to rehab in. And so we've been really grateful to have that partnership to not only provide those shoes for our patients, but for the local community. So we've done like girls' orphanages, we've done schools. We went to Tanzania last year. We brought 4,000 shoes with us on top of our implants. But it's really surrounded on we partner with a country, a surgeon that somebody usually connects us with, who's got a strong interest in doing joint replacements. And probably the most interesting story is when we went to the Congo, we did the first knee replacement in the Congo. And it was through someone meeting Dikembe Mutombo, who, rest in peace, unfortunately passed away. But
Yeah.
he named a hospital in the Congo after his mother. And he was like, these people can't walk. Like, can you guys come help us do joint replacement there? And that was probably one of the most influential, trips we've ever done just because there was no infrastructure. We were coming up with infrastructure, how we were going to educate our patients and the surgeons there to take care of the patients afterwards. Usually we had somebody in country that was trained or had seen a joint replacement and wanted to get the program started. Guyana is another country we partnered with. They're now doing 100 joints a year. So we've not gone back. Our team's been there before. One of the Tanzanian surgeons last year, they actually spent time with me last fall. They were here in Chicago for 3 months, just learning joints, getting acclimated. And the biggest issue is actually distribution of implants in Africa. That's probably the hardest thing to get, but the talent is there. The drive is there. The patients are certainly there. So we actually have now built an EMR with the teams that we partner with. So I see the X-rays before they get there. I see all their post-ops. They send us pictures of their wound. We basically rotate on how we're following up with a surgeon and patients there. And Dr. Daniel Yosef, who we partnered with in Arusha last year, is actually now doing a 1-year fellowship with a colleague of ours who now practices in Lagos, Nigeria, doing joints. So what I love about the global community, it's so tight knit. And we're there. We hope to just be human connectors. We never are there. We're there to provide skill set and protocols, but empowerment, right? And as someone from East Africa, it's like that's what we need is not coming in to just do surgery. It's the wrong thing to do entirely.
That's so profoundly cool that you've built, but now you've built in multiple different environments, and you've been able to take a step back and build it even more of a foundational level, which is, because in this country, I think a lot of people make assumptions, right, about, oh, medicine is the same everywhere. And you're like, God, no, no. In other countries, when your knee and hip are arthritic, it's game over, my friend. I mean, if you're lucky, you have like a walker or something to get to the market. But the notion that there are so many countries where elective surgery really isn't a thing. What's that like? What's that like going somewhere and trying to find distribution for implants? Like, I mean, I got to imagine that in many ways feels like MacGyvering, putting things together.
Yeah, the what we've done is, and the beauty of this is like, industry relationships I think are really important, and many surgeons have industry relationships. We've always gotten our implants donated by Zimmer Biomet, so we try to connect with the local distribution, and they really help us try to get there to try to provide access. And I guess the biggest thing is price points, right? People have to pay out cost. But now, like for example, Guyana, because of this increase in oil funding, they're now providing free joint replacements through the public health hospitals. And it was because we were coming in and providing joint replacements and seeing the impact again from the broader level. I mean, Guyana can see like if people are moving and walking, they're working, right? And so that's how we sort of see things. And I think how we partnered with governments while we were in country to say like if people are moving and walking, they're not using your resources, they're working. I mean, and they have just a better quality of life, right? They're living longer and they're healthier.
Yeah. Yeah, it's interesting. A lot of times, I think surgeon relationship with industry kind of gets written off as something negative or nefarious. And we have all these sunshine acts saying that, doctors are never allowed to receive a pencil or whatever it is. But I think the reality is that companies like Zimmer Biomet actually genuinely do care about the community, and I think it's a nice opportunity to be able to partner with them to make things happen that honestly otherwise wouldn't be able to happen. So props for using the tools in your toolbox to make these things happen. How did you get hooked up with the shoe company?
Yeah, so Wogo has been working with Souls for Soul for a long time. It was actually a volunteer. We have 60 volunteers who come on these trips from all aspects: PTs, PAs, nurses, like every part of like the care aspect, and then volunteers like Tiffany who work for Souls for Soul who just wanted to come and work with us and saw what we were doing, and we've had almost a 15-year partnership with them. But it is part of our, and I think what's so special about Wogo, it's not just about the surgery, but we spend 2 days not only educating the teams there, but also we just go into the community, right? Let's meet people. Let's talk to people. Like, how can we help? And shoe distribution is just one small aspect of that, but it's the power of getting 10 women together. And honestly, Wogo saved me. Like, I felt very siloed by the time you get to end of fellowship and you're just with, the culture of orthopedics for a very long time, it gets really exhausting. And sometimes you're like, do I really want to keep fighting this? And explaining in every space that I'm here because I'm talented and not because I'm Black or a woman. Like, it just gets exhausting after a certain time point. And it was actually Wogo. I went as a fellow. We provide scholarships. We bring residents, fellows, and medical students with us on our trips. And that was the first time I ever saw a woman do a joint replacement. And it was life changing. I was like, oh, you move it this way? Oh, I should do that. That much easier than doing it this way. And just seeing how somebody else does it with hands that are 6.5 glove size like mine, like just as simple as that. But they're my Wogo sisters. Like we run the team ourselves. A lot of teams are run by admins and coordinators. It's run by the surgeons for us. We raise all the money. We bring all our team members. Northwestern's gracious enough to send us all our equipment that we need in the operating room, from the drapes and the knee packs and the suture and the gloves. But we all, it's all fundraised by us. And I think when the surgeons are intimately involved in that, things can kind of go awry. But we're so proud of what we've built and we're growing. And now we're talking about, like, do we need to grow outside of joint replacement? Like, there's a lot of patients who got meniscal tears who need some help, and rotator cuff tears and foot and ankle problems. Like, do we need to provide other areas of orthopedics that are just as, if not more, impactful?
Yeah, please sign me up. Seriously. I mean, from a sports medicine perspective, I would love to spend multiple months a year outside of the country. I took my first medical mission when I was 15. My mom sent me to be a bodyguard for my older sister, and I worked at a clinic, a very in a poor city in Costa Rica, and it was by far the most profound experience I've ever had. Just to I'm sure many of the things that you've seen, when you see something who's been given nothing, not even a pair of shoes, how could your heart not so deeply bleed for that? So, yeah, I mean, please sign me up if you ever, I won't be doing a joint replacement, but I mean, maybe saving a meniscus can help.
I said to Steve, like, if people was, oh, it's so nice that you help all these people. I'm like, it's these trips are not for that. It's for me. Like, it changes me. It's what I need every year to just feel grounded. Like, and as you guys know, you're in this rat race constantly, especially, I work for a big health system, the academic rat race, getting the next patient on, the next revision. And you sort of just forget. And it brings me back down to like the roots of why I'm doing this on a daily basis. And so
Yeah.
I don't get stuck in the mindset of like, ugh, why am I doing this? Why am I looking at RVUs, the cost? It just takes you back into the root of why we went into medicine.
100%. To zoom out and to remember that you're there not to stack an RVU, you're there to change a human life. Because you're right, there's on a daily basis, things get stressful, workflows get put in place, and before you know it, you find yourself becoming someone who's really not who you wanted to be. So, what's it like being so young? I mean, you're so young. We both are.
Thank you.
But, seriously, I
Sorry.
mean, and you're in these roles, you're in these roles that are poised to transform orthopedics for the better, strongly for the better, in my opinion. What's that like being so young?
I don't feel young, but thank you for that. For me, I've always thought, like, if I don't do it now, when are you going to do it? Right. And so there's always, I do believe there is time for pause in your career. And I felt that very early on. When I was in my first year of practice, your inboard collection, as you know, Steve, is super stressful. I ended up having my daughter at 26 weeks with preeclampsia in August of board collection. So I had like another month and a half. And I remember having to go back to work, going to the NICU every day, and I actually stepped off the Women in Arthroplasty committee at ACAS. I stepped off everything. And I remember telling Diane Wayne, who was my boss at the time, Northwestern, at the time I was director of diversity and inclusion, I was like, I need to step away because my life is in shambles right now. And she was like, you don't need to step away from your job. You take care of you. We will figure out the rest. And she's really just a true mentor and sponsor. She's now CMO of the hospital. But every step of the way, she's like, just take a pause. And at that point, imagine people who don't take a pause. Like I've never taken a pause in my life. It's just go, 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 go. So that was a huge adjustment for me. And I even look at like I did nothing. If you look at my publications in those 3 years, it was zero. And I thought my life was over. This whole like academic life that I imagined, because I had to take time away because my daughter had surgeries. There was PT, there was OT. Thankfully she's doing really well and just finished kindergarten. But it was a probably 2 years of solidly just focusing away from medicine where my volume was down, my publications were down. I wasn't as present for my trainees and mentees, but I had to step away to take care of my family. And at that point in time, I thought life was over. Like, I was like, why am I even doing this? Like, let me just leave medicine and orthopedics and figure something else out to do. Cause, I have this blip in my life now and I'm never going to be able to recover. And the one thing I will say is you could always recover. And if your time, and then as soon as she got to preschool, I'm like, okay, she's doing great. Like maybe it's time now for me to sort of get back into the things that I'm passionate about. And I just went back to it. Right. And it was always there. Your patients are always there. You're booked out. They're going to come back and find you. The next paper will be there. It's okay to sort of get a little bit behind, step away, and then come back again and take care of your family. And it's the best thing that ever happened to me. If you asked me at the time, I thought my life was over. I was crying all the time. My husband's like, your life is not over. You will be fine. But you just needed like the people around you. And again, it goes back to community to tell you life is not over. You will be fine. Your kid will be fine. Your career will be fine. But it's going to come and go. And right now I'm in a phase of, I would say, like, I've got the time, I've got the family support to be able to do the things I want to be doing. Will I have to step back at some point? Probably, right? We all do. Our parents are aging. That may be a time that I got to step away and help my parents. But life is not over. And I think we get stuck in the comparison game. And you just can't compare yourself to what all these other people are doing around you. It may be a good time for them to be, you know, taking off in X, Y, and Z realms of life, but it just may not be the right time for you right now. And I think the biggest thing I've always lived by is I'm not somebody else. I can only do for me and my family. And I just have stopped comparing or caring about what everybody else is doing. I'll do it on my own timeline. And my timeline may be faster sometimes.
Yeah, I
Would
love
you
that.
say giving yourself that grace it was basically a learned grace. You had been going so hard for so long. Do you think that grace that you learned when you stepped away with your daughter has something you've taken on to furthering your career?
Yeah, I think I've become more patient. I think that I've learned that even with decisions in leadership roles, that sometimes I need a little bit more time to really think about this, process this, what decisions and how will that affect change. It's really just taught me to pause, and that's something really hard for us as surgeons is just taking a pause and thinking about things and not rushing to the next decision just because we need to make a decision.
Yeah. Yeah, I think it's, as orthopedic surgeon, it's easy to kind of justify our value based on that title or how many joint replacements you're putting in or whatever it is. But I think at the end of the day, to me, it's much more obvious that what defines you is your mission on this planet. And that is something that is much more profound than replacing joints. It's kind of the essence of who you are. And that doesn't go away just because you're going through some of the hardest challenges that you would ever need to go through. But in the time, I totally agree with you. It can definitely feel like the crown is being stolen. Well, I see why Dr. Bozick selected you.
Just has been a true honor to speak to someone such powerful in the world of medicine. And thank you for being a good leader for other women.
Thank you. Thanks for having me.
Any other messages, Melinda, that you want to give to a young woman or whoever may have you that's listening to this podcast and isn't sure if they're able to do or accomplish the things that you've accomplished?
Yeah, I think the one piece of advice I'd give to any younger surgeon is enjoy the journey. And I'm a big believer of actually taking time to think about the journey you've been on, where you've come from, what you're on now, and what the future looks like. I think we are really stuck into, again, like you said, Steve, these accomplishments and the number of cases and the ticks on my hat and, am I chief? Am I chair? You know, we got to just think about like, what growth have I made in 6 months? And really like stopping and reflecting on that and writing it down. Sometimes you just need to open that book and say, oh man, like I'm actually not doing so bad. I've had a couple publications this year. I've done this in the last 6 months. I've done this in the last year. And I think just writing it down really helps. And it just helps me, honestly, is the gratitude aspect. Is just sometimes, we're really blessed that we get all these opportunities, but just be grateful for what you've accomplished, the people around you who've helped you get there. And ultimately, what keeps you leading is just lead with kindness. I mean, that's the best thing I can say is just lead with how you would want someone to treat you. And we just the human heart. Like, don't you're not just an orthopedic surgeon. Like, I want to get away from people being just orthopedic surgeons.
Yeah, preach. So, okay, so Linda, you have an important task. So next episode of podcast, or sorry, the Scrub podcast is going to be our last until we go away until season 2. So you are picking the last person for season 1, and without further ado, which orthopedic surgeon should we interview next?
So I think you should interview